Dr. Griffiths and his team found was that I believe about 80% of the people in the psilocybin group reported that it was a top 5 most important experience of their entire life. So this experience with psilocybin was up there with the birth of a child and the death of a parent. And I remember this bell went off in my head and I kind of made this connection that, wow, there is something here worth looking into. And the neuroscience books that I'm reading do not cover this. This is not properly situated in our science right now. And also this inspiration, this idea that, wow, people are doing this. And I'm really forever grateful to Roland Griffiths for that.
Welcome to the Future of Psychiatry podcast, where we explore novel technology and new innovations in mental health. I'm your host, Dr. Bassi, an addiction physician and biomedical engineer. Today, we are with the real Dr. Adam Levin, who is a psychiatrist and affiliate scholar with the Center for Psychedelic Drug Research and Education. Dr. Levin is a resident in the Department of Psychiatry at Ohio State University School of Medicine, and he received his medical degree from the Louisiana State University School of Medicine. We welcome Dr. Levin here today to enlighten us about a topic that is gaining so much popularity recently, both in research and clinically. And it's quite the large bandwagon that's getting bigger and bigger. And we want to know, is this bandwagon warranted? Welcome, Dr. Levin.
Thank you. Thanks so much for having me.
There's a lot to talk about here, and I know that you have a lot of research going on that you're interested in, especially when it comes to psychedelics for treating addiction. And I want to get to all the most interesting tidbits about this topic. When would clinicians think that this is most useful to refer a patient to them? But I want to first get started in talking about, how did you get interested in this field of psychiatry? Obviously, there's a lot of other fields that you could have focused your attention on, but what is it about psychedelics that really interested you?
I was the type of kid who was really more of an English and history person in high school. And then when I went to college, I was really focusing on kind of the humanities and with this kind of idea that I wanted to be a physician. My father was a physician. And so I kind of split my coursework between the neurosciences and history and English and became fascinated with the time period of the 1960s and 70s and really just sort of did like a minor in that time period and ended up taking a lot of history and reading a lot of literature and started making this connection that there was this cultural transformation that occurred and that psychedelics, this drug, were somehow a really big part of this. And I couldn't wrap my head around it. I was reading a lot of the beat poets and trying to understand the hippies and all these other things. But in my neuroscience classes, I was also learning about drugs and learning about psychedelics. And the paragraph, I remember looking at my neuroscience book in this class called Drugs, Brain, and Mind. And the paragraph about psychedelics was, really short. And there was a lot of other information about drugs. And I remember thinking, this can't possibly be the full story here. It's not matching up with what I know about the cultural shift that happened. So I remember a day that I went into the library and I was kind of Googling the psychedelics and psychiatry. And I found a paper by Roland Griffiths, who unfortunately passed away a few months ago. And this was kind of one of the first studies in the early 2000s, which was in healthy volunteers comparing a dose of psilocybin, so that's in magic mushrooms, the active ingredient, with Ritalin. And what Dr. Griffiths and his team found was that I believe about 80% of the people in the psilocybin group reported that it was a top 5 most important experience of their entire life. So this experience with psilocybin was up there with the birth of a child and the death of a parent. And I remember this bell went off in my head and I kind of made this connection that, wow, there is something here worth looking into. And the neuroscience books that I'm reading do not cover this. This is not properly situated in our science right now. And also this inspiration, this idea that, wow, people are doing this. And I'm really forever grateful to Roland Griffiths for that. And it's interesting because my current mentor, Alan, was working directly with Roland at Hopkins. So it came full circle, but that was kind of the inspiration for me. And then that was in undergrad. And from then on, it was always, as I moved through medical school and into residency, it was always in the background that this is something really powerful worth looking into.
When you talk about psychedelics and maybe the patient you're talking to thinks that they might have such a profound experience on par with having a baby, that can be either really frightening for that person, perhaps, or it could be exciting. Like, wow, there's a potential out there for something to help me that is really kind of miraculous in a way that has such profound impact on my psychology. and maybe that is the thing for me. How has your background and experience and research helped inform the way you talk about psychedelics with patients, or help maybe inform them more correctly of some misconceptions they have?
Yeah, so I think you're highlighting something important, which is that I feel really a great responsibility about these experiences because they really are precious to the people who have them and they really are important and they can be destabilizing, right? You're talking about an experience like the birth of a child that is significant. And to have that associated with going into a doctor's office and taking a drug can really upset someone's worldview. Something that's important to me is that we're very careful about how we frame these experiences and also how we support people. And some things that have helped me, interestingly, is that kind of grounding in literature, history, and even exploring some of the spiritual literature, because I want to support people going through these experiences and understand what they're thinking about them. I don't want to project my own sort of ideas. I want to get as broad of a grounding in different spiritual traditions, as well as psychiatric traditions, psychological traditions, so that I can provide that support. Because again, I think often people can be destabilized. And there's a term for this called ontological shock, which I believe Roland Griffiths coined, which is indicating this is really upsetting, can be upsetting to the base of what people believe. And so we have to be very careful and supportive in these situations.
I feel like there are likely kind of two camps of individuals or patients who may be more or less inclined to think about psychedelics. There's the ones who have tried a lot of other options and they feel like they're at wit's end. What else is there for me? There's this new option. And then there's people who, for the reasons that you're saying, maybe have a biased interest towards this topic or idea. Maybe they've experimented with cannabis, or they have a history or an interest in history from the 60s and 70s, or an aversion away from the pharmaceutical industry. And they have other sort of biases towards trying something like psychedelics. Do you think those preconceptions, not only one, could have implications on the placebo effect clinically, but also a bias in clinical research of patients who may be more interested in enrolling in a trial, looking at psychedelics, their efficacy compared to placebo? Maybe there's a selection bias there that shows that the psychedelics are maybe more effective or whatnot. There's a lower dropout rate because those people have some sort of background bias towards psychedelics. Because what you're describing sounds to me like, in your history kind of speaks to this as well. I think clinically it parallels my experiences when I'm talking to patients. There are some people who are just inherently interested in this topic for whatever reason, and then they bring up that in conversation.
I think there's a lot of things going on now. I think there's an initial interest from people who probably have had experiences with psychedelics or heard of psychedelics. And then there's this wave of interest in the media that's happening over the last 2-3 years, where people are coming in already with preconceived notions of what's going to happen, that this is some kind of miracle cure, which it certainly isn't. We can talk about that more. But so there's this positive valence right now, and it certainly is going to affect outcomes. And there's certainly an enhanced placebo effect. That's true of all interventions. You see when a new intervention comes, even with something like Prozac or an SSRI, there's kind of this initial bump and initial positivity, and then it kind of flattens out. And so I think we're due for that with psychedelics. There's no doubt. And we have to be aware of that when we're designing trials. What we try to do now with trials is to recruit people specifically with very little or no experience with psychedelics, because in that way we can at least filter out some portion of the population that may already have a preconceived notion. Now, it's hard to filter out all the media bias, but that's just part of it.
Let's talk about psychedelics and addiction. I feel like that's not getting as much attention maybe as just psychedelics in general for mood disorders. I was reading some article that mentioned that most people attribute some of the benefits to the insights that they gained while they were influenced by the drug more acutely. So there's that psychological component, and then they are also psychoplastogens, and that helps with rewiring of the reward circuitry. Maybe you can help kind of weave this question into what your current research is. Maybe this is kind of accounts for why psychedelics are perhaps on par or exceeding in effectiveness compared to SSRIs, because with SSRIs, you don't have that profound level of insight as when you're on a psychedelic. But yeah, tell me a little bit about what you're doing research on in regard to addiction in psychedelics.
I think it's worth digging into a little bit what you just highlighted, because I think that's actually at the center of the field right now, which is you have these acute subjective effects where people are taking the drug, they're sitting in a controlled environment for 8 hours, and they have these profound experiences. We can measure those subjective effects, and we know that those effects are correlated with outcomes. So the higher the person's insights in that acute experience, the stronger the ratings of what we call mystical experience, the better the outcomes. And that's true not just in addiction. it's also true in depression and anxiety. So there's this correlation that we know exists, and that's been very well validated. On the other hand, we have the biological effects, right? You're taking a medicine, there's some effect in the brain, and it's causing, many people are looking into this idea of psychoplastinogens, which means increased dendritic growth, changes in certain areas like the hippocampus that are associated with depression. So there's the biological side of it. And so what's happening now, people are asking questions like, well, can we just take out the subjective effects of the drug? So the person doesn't have the trip and they just have those neurological psychoplastinogen effects. And would that help with addiction? And would that help with depression? Or are the subjective effects centrally important? Is it really the subjective effects? Now, I think it's both. I think it's probably a window of plasticity that's being influenced by those acute subjective effects. I think that's what makes these very unique as opposed to SSRIs, like you mentioned. So I think the combination of those two is really what's leading to these profound changes. Now, in our research, a lot of what we've been looking at recently are when we give a psychedelic, it's in this container, this therapeutic container. We have about 8 hours of therapy before we give the drug in a controlled environment with 2 therapists, and then we have therapy after about 8 hours. And so we're looking at different components of the container, like the therapeutic alliance, and seeing if those things correlate with outcomes. And so in that way, we can kind of center in on some of these aspects that may be having more of an influence than we realize.
I recently stumbled upon something that could very well change your clinical workflow. I always thought having a medical scribe was only for busy ER doctors. Well, with the release of all the new AI tech, a company called Lindy developed an AI-based note writing scribe app, and it works phenomenally well. You start your patient visit, press record, and it listens and transcribes and then outputs your note exactly how you want it. What I like the most about it is that you can customize exactly how you want your note to come out. And that's different from some of the other AI-based note writing apps out there. For example, if you want 5 sentences in your intro and you want to include quotes, psychotherapy themes discussed, it will do exactly that. Or if you simply want to dictate and use short phrases in your dictation, you can do that too. It can also give you follow-up instructions, referral letters, and consultation notes. Absolutely amazing. You can even use it for other AI-based tasks. It will save you so much time and make you more engaged with your patient's visit. Sign up now at lindy.ai/Bruce for a 7-day free trial with absolutely nothing to lose. And Lindy is giving listeners of this podcast 50% off their first month. That's lindy.ai/Bruce for 50% off your first month. Please go and check it out. I can guarantee you that you will be amazed at what you see. Now back to the episode. So let's maybe make this as useful as possible for a listener who maybe treats patients with substance use disorders. They go through the traditional types of recommendations. Maybe the patient's gone through a rehab program and now they've dropped down to regular outpatient programming with a therapist. Maybe they're on naltrexone or Vivitrol or Suboxone. They probably have failed maybe a couple of those. I know there's not formal recommendations for this, but when would you recommend, maybe anecdotally, and what is the research telling us about, maybe there isn't any answer to this question, but we could speculate. Who should be thinking about this as a recommendation for their patients?
Yeah, that's a good question. We're very early with this, but in terms of addiction, the furthest along are tobacco use disorder and cigarette use. So some of the early studies at Johns Hopkins were looking at tobacco use disorder. And what they found were that in this therapeutic container, right, with the preparatory therapy, which was in that case, I believe CBT, followed by the psychedelic, I believe there was about an 80% at 1 month of complete cessation of smoking. So that's significant compared to what we have currently, which are nicotine replacement and Wellbutrin. That tells me that we might at some point be considering this as a first-line treatment for smoking cessation. There's a bigger trial that's ongoing. There's NIH actually pouring funding into this. And so that may be the first clear evidence for psychedelics with addiction. There's also been a larger trial using placebo in alcohol use disorder, but this is an outpatient treatment. So this wasn't, inpatient treatment and then received a psychedelic. This was people who were drinking, but receiving outpatient substance use treatment and then entered into this clinical trial. And again, we saw with this trial large decreases in alcohol use, sometimes complete abstinence, that was better than placebo. So I think, those are the two big areas. I think people are looking into opiate use disorder. There's a lot of promise there, but I foresee this being probably an patient or partial hospitalization level treatment where people maybe go through some sort of 8-week or 6-week program in preparation for receiving the psychedelic, receive the treatment, and then follow up after that. I think that's probably where this is heading. Although again, that's kind of my first guess and it's very early.
That's pretty interesting. Really interesting to think about the use of that for treating addiction. I know it might sound counterintuitive to certain individuals who might not have experience using Suboxone, for example, for an opioid use disorder. But I think in the right conditions, the right patient, the right setting, the right access to it, and the right environment, like you're talking about, I think it can reduce the potential for that addictiveness with the substance.
I often tell this story in my presentation. I think this is an older idea than we give credit for. In the early 1900s and before kind of the advent of Alcoholics Anonymous, there was an American named Roland Hazard who traveled to Switzerland. He was an alcoholic and he couldn't get clean. And he traveled to Switzerland to see Carl Jung, who, you'll probably know is kind of one of the forefathers of psychotherapy. And he went through this intensive therapy with Carl Jung. He ended up sober and back in the United States, and he asked Carl Jung, how do you think I can maintain my sobriety? And how do you know that I'm cured? And Carl Jung basically told him, I don't know that you're cured, but one thing that you might seek out or open yourself to is a spiritual experience, a transforming spiritual experience. And Carl Jung said, in my patient population, I've seen this work. I've seen people have these experiences leading to sobriety. And ultimately, Roland Hazard ended up meeting Bill Wilson, who is one of the founders of Alcoholics Anonymous. And Bill Wilson starts this correspondence with Carl Jung and tells Carl Jung, hey, I actually had a spiritual experience when I was in a hospital in New York. And that was my inspiration for founding Alcoholics Anonymous. And he described being in this hospital, going through detoxification, seeing kind of a bright light, having all these realizations, essentially a psychedelic type experience, and founding Alcoholics Anonymous, and really found Alcoholics Anonymous with the idea, and he says this, of opening people up to transformative experiences. And what a lot of people don't know about Bill Wilson is that in the 60s, he actually took LSD in a controlled context with therapists, and he ends up writing actually to Carl Jung that this experience that I had with LSD was similar to my original spiritual experience that I had in this hospital. And he suggests even that LSD might be used as a treatment for alcoholism. So we have this kind of rich history, and this is something I'm fascinated by because a lot of researchers in this space have described rediscovering these older ideas that have been either on purpose or perhaps just because psychiatry has moved so far away from this. These ideas have been kind of glossed over or covered up, but they're in our history. And so I think that's fascinating.
Yeah, it is really interesting how it all kind of comes together. Everything's kind of interrelated in the psychiatry world. I know there's probably a lot of studies out there. I know you're not recruiting for anything. That's not why you're here. But if somebody did want to get more involved, either a clinician or a patient, what would you suggest other than Google searching? Do you have any specific suggestions for them?
MAPS, the Multidisciplinary Association of Psychedelic Studies, maps.org, they have been funding this research since the 80s and have a lot of really good information about clinical trials and just in general. And they have things like trainings and other things for clinicians. And for patients, they offer a variety of resources, including clinical trial websites and things like that. Our website, cpdre.org, where we have resources and plan to begin hosting clinician training. Because I think ultimately, as these things become available, as you mentioned, I think having clinicians who are trained and having availability of training, because this is quite different than what we typically do, will be very important. So I think looking at MAPS, looking at our website, there's another CIIS.org, I believe, Center for Integral Studies, California. Can't remember the exact name, but it's CIIS.org. I think is a really good resource as well. And they have different training opportunities.
Why do you think it's important to have training for psychedelic treatment? But hopefully this is not opening up a can of worms of discussion, but I can't recall one training or certification process for medical marijuana, for instance. Do you feel like this would help preserve the integrity of the field as we approach psychedelics so that it doesn't get too out of hand? Because there is this temptation and a tendency for the field to just suddenly explode with startups and this unquenched thirst for the interest of psychedelics that can't be met by the current resources. So all these other kind of sub-cottage industries kind of pop up to capitalize on the demand. What can we do better than I think it was about maybe 5 or 10 years ago when medical marijuana just kind of bloomed. It's an algae bloom. It was way too quick.
You're right. There's like a whole ecosystem that comes up around these things with the hype. Many of them, whether on purpose or on accident, are looking to take advantage of the situation. They're not careful. And with medical marijuana, I agree. I think it was this kind of explosion that became uncontrolled and actually was kind of taken over by industry. And in the same way that I think the tobacco has worked. And so there's all these interests that are pushing things. I hope that we can be more responsible with the way that we bring psychedelics forward. They're very, very different than cannabis in a lot of important ways. So what makes me feel hopeful, I guess, about psychedelics is that no one is really proposing, at least within the field, and even outside of medicine, very few people are proposing that anyone should be able to just go into a store and buy a large amount of psychedelics and leave. I think even in places like Oregon, where they're trying to roll out this model of using psychedelics outside of the medical framework, they're stressing the importance of having a controlled set and setting. Setting is the physical environment of taking the psychedelic, and set is the mindset, which means preparation and support and really kind of intentionally going into the experience. And so that's being stressed in Oregon, like I said, which is outside the medical model. And it's also very, very much stressed within the medical model. And so I think when the FDA and DEA come to their decisions about approving these treatments, they will approve them only within these specific containers. So only within these therapeutic supportive frameworks, as opposed to here's 5 grams of mushrooms, go do them on your own and try to help yourself, which I think industry gains control. Things can tilt that way sometimes because it's a way of making a lot of money without putting in a lot of support.
Why do you think that is important for us to have that more conducive, supportive, safe environment for individuals? I'm sure there are going to be listeners who say, well, I'll forego those risks or those recommendations and take the risk and just do it my way. And maybe I would prefer to just kind of gain those insights in the comfort of my own home without having to talk to a therapist.
I don't necessarily have a moral issue with people using, psychedelics on their own. And I'll also acknowledge that psychedelics compared to other drugs are relatively safe. So there's no real risk of physical overdose, right? There's not a lethal dose known, LD50, which is, a term for lethal dose known of these psychedelics. They seem to be physiologically well tolerated, right? And also there's no real risk of dependence in any traditional sense. There's no risk of withdrawal. But what I will say is that there are some immediate psychological risks, right? If someone takes a high dose of psychedelics, they can be very detached from reality. They can become confused. They can run out into the street or get themselves into dangerous situations. So there's that, you think you want to have someone supporting you who can really prevent that from happening. And many people who are using psychedelics outside of medical context do acknowledge that they'll have supportive individuals. But I think one of the biggest things is that the psychological risks, they're different than the risks of taking drugs and overdosing and dying. Psychological risk can be significant for all those reasons that I mentioned. These experiences can be shocking. They can upset your worldview. And if you're not prepared properly going into the experience for something like that to happen, they can be quite terrifying. And those can have effects. They can have significant consequences in a person's life, anxiety and questioning things. And so my belief, and there's evidence for this, right, in our work, if we provide this structured environment and help the person to navigate the space, they'll really get significantly more healing out of it, first of all. And second of all, I think they will be much safer and have better long-term outcomes. So, that's really where my focus is.
This episode is brought to you by Charm Health. If you're in the market for a secure, stable, easy-to-use EHR system, this is the place for you. I've been using Charm for over 5 years, and I've found it to be the one EHR system that I've used where I'm spending more time thinking about my patients and less time thinking about charting. It just makes everything so easy. It has everything in one spot, and their pricing is extremely transparent, unlike many other EHR systems. Every feature that you want in an EHR, Charm has, from dot phrases to e-prescribing to document management, scheduling, and billing all in one. I've studied EHR usability and also did a podcast episode on EHRs, and I can safely say that Charm is among the top in clinician satisfaction. Not to mention, they are always releasing new features, and not just to stay abreast on the current market, but user-requested features as well. They are extremely open to feedback and improving, and I've gotten to know many of them at the Charm-A-Lot conference, which was a blast. I highly recommend Charm, and I think they have a phenomenal EHR system. Reach out to me or to someone on the sales team to schedule a demo, or visit charmhealth.com for more details. That makes a lot of sense. I think that's a great answer. I hope people really heed that advice moving forward. I know you also have interests in using psychedelics for individuals with depression diagnosed with cancer. I think that's one of the most difficult to treat types of issues, an individual who has maybe terminal cancer and is struggling with depression. And then you also have an interest in the study on psilocybin assisted therapy with veterans and PTSD, another very difficult type of disorder to treat. Let's start off with the 5-MeO DMT, a shorter acting psychedelic, and the comparison with psilocybin. Tell me a little bit about what the latest research is showing, and are you excited about that?
Yeah, so like you mentioned, patients at the end of life, and especially patients with cancer, and we're looking at lung cancer, which is non-small cell, which is a very difficult diagnosis. They suffer from depression, a lot of depression, a lot of anxiety, a lot of angst surrounding the end of life. And what we know about psilocybin from previous studies is that it can be very helpful for depression and anxiety at the end of life. So these are studies done at UCLA and Hopkins and NYU. We have a lot of evidence there. And we see that the most exciting thing for me, the most exciting potential for me is, we're not suggesting that psilocybin is going to cure cancer, right? That's not what we're doing, but maybe, and what it seems like is that people who have these experiences and have this kind of mystical type experience, these insightful experiences, that maybe they can live the rest of their life more connected to the people they love, more connected to their values, more aware, more present. And in that sense, maybe their quality of life can improve, their satisfaction with life can improve. And that would be significant. And so there's evidence, like I said, and this is a very, I would say this is one of the three, with depression and addiction being the other two, one of the three indications for which we have the most empirical evidence at this point for psilocybin. So what we're doing, so we're kind of building on that evidence and looking at lung cancer, which has not been looked at before. And we're also comparing it to this, as you mentioned, this shorter acting psychedelic called 5-MeO DMT. Interestingly, 5-MeO DMT is found in the venom of the Sonoran desert toad. And that's where we're not really sure if there's evidence of, long history of indigenous use, but people have been using it this way, smoking this venom for, at least 50, probably maybe more years. And so that's where that kind of evidence, and that's where this compound is found. It's also found in some other plants in the Amazon, but it's basically a shorter acting. So it's about, depending on the route of administration, it's about 30 minutes to an hour. We're doing intramuscular administration of 5-MeO DMT. People seem to have these breakthrough spiritual type experiences, and then, they're able to potentially leave the clinic within a few hours, which is different from psilocybin. Psilocybin, it's a full day experience. If it works, if it's helpful, this would be in terms of cancer patients who don't necessarily want to spend or have the time to spend a full day in clinic doing this between appointments. It would be really helpful. The other thing is there's evidence of 5-MeO DMT in just depression. So we know that it can be helpful in depression, and this would be kind of the first looking into this specific population. So, I'm really excited about it. I think having a shorter acting psychedelic would make this more available for people, and it might cut costs down, which is something that I think about, right? Because if you're doing a full day of therapy with two therapists, that's going to be expensive. So maybe this is a kind of way to have a lower cost.
Yeah, the irony is not lost upon me for running a podcast on innovation and technology where companies are spending millions of dollars on the latest glamorous piece of technology, and we end up just smoking toad venom at the end of the day.
It's funny, but I think, again, part of this is that we're rediscovering these sort of older ways of approaching mental health and wellness. I think, the 5-MeO DMT piece, the toad venom, not sure how long we've been doing that, but certainly with ayahuasca, which you may have heard of as a Amazonian psychedelic brew, I mean, that goes back thousands of years. And there's suggestion now that even going back to the beginning, the roots of Western culture in ancient Greece, there were uses of psychedelics in the Eleusinian mysteries. And so it seems like we're going through a period of kind of remembering some of this heritage. And it is kind of ironic, right? Because we're this super technical, hyper advanced society. But my view is that, and it's interesting, is that there's things that are missing. And so maybe we're kind of rediscovering these things. And I think it will change the shape of psychiatry in a really significant way, and more. It'll go beyond psychiatry, I think. So it's really interesting.
Yeah, and leading into the discussion on PTSD, and I think there is some crossover there because I've had patients who have a terminal illness or lung cancer who I feel like almost have a type of trauma reaction based on the
Yeah.
diagnosis being received and the medical workup
Mhm.
thereafter that just spans so many different departments of the hospital, from radiology to oncology to internal medicine to cardiology and the effects of chemotherapy. They get medicalized and end up having a traumatic reaction, post-traumatic reaction to that medicalization. I know
Definitely.
that you are involved in a clinical trial of psilocybin-assisted therapy, which has shown a lot of promise in, I think, the first phases of some studies that were published already. But tell me, what is the latest research showing there in regard to, people call it PAT for short? Probably not yet.
Not yet. There's a lot of debate about that. I think we're still developing. Some people say psilocybin treatment, but we say psilocybin assisted therapy. I think that's accurate for what we do. At least we're really doing a lot of therapy in these treatments. So with veterans, so we have this clinical trial with U.S. military veterans with PTSD, and we're focusing on severe treatment resistant PTSD. So people who have tried other treatments, medications, therapy that have failed, and really within the veteran population, they tend to be especially difficult to treat in traditional ways. So this is much needed, and I'll acknowledge that. So MAPS, who I mentioned earlier, they are very far along in their MDMA assisted treatment, assisted therapy for PTSD. MDMA is not a classic psychedelic, but similar type of approach. And so what we're doing is with psilocybin, and we have again these preparatory sessions. We have 2 psilocybin dosing sessions, then we have follow-up therapy. And so I think with PTSD, especially, a lot of what might be happening is people are able to come back, revisit some of these traumas that have happened, but do it from a place of love and a place of compassion and a place of acceptance. And ultimately, that's where many of these therapies that we try to use, cognitive processing therapy and other things, that's where we try to go with them. But it seems like with the psilocybin, there is some sort of internal process or healing pathway that's opened up where people just go there with the correct preparation. And so many veterans, many patients who I've worked with can kind of view these experiences, these feelings of guilt and shame, and really let go and have kind of a restructuring of that. And so I think with PTSD and with trauma, as you mentioned, it's everywhere, right? Even with cancer, it's there. There's childhood trauma. So I think ultimately trauma can be at the core, and people have written extensively about this, can be at the core of a lot of psychiatric disorders. So I think it's really important then to see how these therapies are affecting it.
I really appreciate you and your time and popping in to talk to us before you go off to clinic. I think you
Thank
opened
you.
up a lot of Wikipedia rabbit holes for a lot of people. I know they're going to be Googling some wild stuff today, but yeah, I really appreciate it. And I'll let you give the closing words if you want to tell the audience about where they might be able to find you or the research you're doing.
I'll point you to cpdre.org. This is the Center for Psychedelic Drug Research and Education at OSU, and we have a really great team. I have a great mentor, Alan Davis, who runs the center, and we're working on a lot of interesting stuff. In addition to the trials we talked about, we have several surveys related to people's opinions about psychedelics and beliefs related to psychedelics and changes under psychedelics. And so we have a lot of that going on. We're also focusing on education. We're going to be rolling out some courses for undergrads and hopefully some courses for continuing education credit. Again, I think I'm really grateful for you exploring this topic. I feel like it's exciting and also cannot possibly live up to all of the hype. And I want to be clear that it won't live up to all the hype. And I think it's important to put that out there. But I am hopeful, and I do feel like psychiatry is going into an interesting place and a hopeful place. So I can say that. And then I'll also close with saying, all of these opinions are mine. I am a resident at Ohio State, but these opinions aren't reflecting the ideas of the university or the institution. They're mine.
I appreciate that. Do you want to give us any Adam Levine cover songs on the way out?
I'm a singer, but I'm not as good. I'm not as good of a singer as the real Adam Levine,
No
or
impressions.
maybe I'm the real Adam Levine. So
I share the same sentiment about the excitement about this field. I wish we were further ahead in terms of the research and had established protocols for these types of things, so we just have another tool for our patients to get them to where they need to be. There's a lot of struggle out there with the current modalities. Like you said, we are kind of falling short in some regard. There is something missing.
Yeah.
And maybe it's just been in nature all along and not in a laboratory. Appreciate your time. Thank you so much.
No, thank you, Bruce. I really appreciate it.
That's it for this episode. I'd appreciate it if you please like and share this podcast with your colleagues. It'd be especially helpful for us. If you'd like, please leave us a rating on your favorite podcatcher. If you're a clinician, I developed a course on how to start a private practice. And for patients, I've also developed a course on acceptance and commitment therapy and cognitive behavioral-based therapy lessons for treating and helping anxiety. You can find all these on our website as well as the show notes and resources for each episode. Thank you so much, and I'll see you in the next episode.